And the cost of open heart now is in $1 million plus, even within almost the small average hospitals. If you are going out of the country, I think people are raising almost 3 million to go there.
I normally ask people if they were like a cabinet secretary for the areas of their expertise, what would they like to see done in order to improve healthcare service delivery?
Thank you. That's a beautiful question. As a teacher myself, most of my work currently is about teaching and preparing specialists who can go to the counties to do what we do in the level 6 hospitals. Remember, I said the registered are less than 10 as pediatric surgeons who have qualified. The University of Nairobi trains for Africa, actually, the MPESA degree. The one in South Africa is more of fellowship. Recently, you have heard of our university, I think, with the challenges that we are facing of raising funds to pay for salaries and other things, that the school fees for master's students has been tripled to around 700 and something. Definitely, when the school fees for masters become exorbitant, you are more likely to have no one applying for these courses to come back, because when they come back, they must be with us for 5 years. By the time you have finished your undergraduate, you have become a medical officer there for 5 years, then you get a chance to come. Most of the time you have a family, so you have children. If you are coming back for a master's, you have no salary, you must raise 700 per year, and you must also take care of your kids. That's a big strain. I think then most of the times the county governments or even the Minister of Health, they don't release them. So most of the things from our side is how do we strengthen the programs that would train more of these specialists to go and cover the counties, so that some of these, like Apondi, remember her mother was a medic. Now assume Apondi was in Mandera. Assume she was in Turkana, in some hospitals where there are no specialists. By the time that diagnosis would have been made is when there are now complications, either recurrent chest infections occurring from that heart condition, or worse, when the heart now has been so compromised that even surgery itself cannot improve. So our key messages now is to train our own. That there should be a very strong, at least, program to allow those who want to specialize to come back and be given that chance to specialize and send them back to mashinani. That's the only way to save us. But the government policy, and with the issues of having Cubans come in, that's definitely has been our challenge. That we are almost relying on foreigners to help us when we are not strengthening our own programs. When we withdraw sponsorship for our own citizens to go and master so that they can go back to the counties to help, that is not very nice.
I have found this conversation very interesting, and I'm actually learning so much, so much. One question has come to my mind: if healthcare services that time was free for doing an operation for a child was free, and we were not being taxed that much. What is the cost of healthcare doing the same thing now at a time when we are very hugely taxed? That's a question I was actually asking myself right now.
Apondi's daughter actually was treated free. That's the beauty of government programs. Now, the allocation to government hospitals by there is very little. Such surgeries, even if NHF is paying, patients or relatives still have to top up. And the cost of open heart now is in $1 million plus, even within almost the small average hospitals. If you are going out of the country, I think people are raising almost 3 million to go there. So that is one. train your own personnel. Number two, equip. Kenyans can help each other. If we have enough specialists and enough personnel, even the price of doing those surgeries will go down because there will be competition. And when there is competition, expertise will always improve. Mainly that.
If I was the minister for health, I would be working towards a policy that provides free medical care in Kenya. I would, for me, that would be key, resource use of the resources that Kenyans put together via tax, and that the medical facilities like Kenyatta Hospital, especially referral hospitals, would provide free medical care. And it would not only be free, but it would be of the same quality as my daughter got when she got it 32 years ago. Yes, that high quality that is free. That for me is a key thing that I would highly recommend. I think anything else that I say beyond that would be junior to that particular point. There are countries like Sweden where the taxation is very high. So high that I think they say 60%, something as high as that, 60% taxation, which then means everybody is able to get medical care that they already paid for through their taxation, and it's high quality, apart from the other resources and facilities like education that they are provided. Yes.
I really appreciate fundraising. It's really helped a lot. But if the health systems could be a bit right, the way you've said, if we invested more, in our own homegrown healthcare and service delivery systems, even these harambes are going to be a thing of the past. Okay.
Yeah, and who can afford a harambe? Yes. It's only a certain particular class. What about that little girl who's got a hole in the heart and she's in some back beyond or in Homa Bay County?
Yes.
Or Turkana. She can't afford the kind of harambe that my own family was able to probably afford. Exactly. Harambe is also a thing of the elite.
If the healthcare service delivery systems were in place, Kenyans would really get a reprieve, good quality healthcare, visit hospitals with enough doctors and proper infrastructure and equipment. So that's what I can safely conclude. So Collins Orono, is there anything you would like to say or just put in a word?
Yes, you mentioned something about taxes and healthcare. I think for me, it's not really about taxing more. It's about putting what you have into action, or utilizing effective utilization of what you already have to better the healthcare services. Because I think for me, the loophole is not even in funding. Well, the biggest problem we have is all this corruption and all that, and the willingness to allow systems to work and better the healthcare systems.
Okay, thank you so much for your the answers to the questions that I've been asking or we've been asking each other, and for the engagement. I've really learned a lot, and I hope that when we put this out there, more people are going to do a follow-up and ask questions from that platform. And then I also hope in future we can do such engagements, more on such engagements. Apondi, I'll follow you up on a suggestion you've asked about where these people who come from far away, stay when they come to hospitals here in Nairobi. That's a story that needs to be told. Perhaps we go and see, because I hear some sleep on the benches of Kenyatta hospitals. So that's a good perspective. At least that's why I like interacting and getting new ideas and angles of doing these health stories. So if there's anything else, if there's not anything else any of you would like to add, I can safely conclude that we've come to the end of this discussion. Is there? Okay, it's okay for you and Collins. Okay, so we've come to the end of this long discussion. It's been informative. Thank you for sparing your time to be with me. I don't take it for granted. And the discussion has ended here. I'll post this on my YouTube channel and I'll share the links with you. And I'll be reaching out to you again in future if you allow me, so that we can have such kinds of discussions. It's bye-bye from me.